I'm Selma Schimmel, and reporting to you from the 35th ESMO Congress happening in Milan, Italy. And we are now going to spend some time with Professor Jean-Charles Soria, who is visiting Italy from the Institute Gustave Roussy in France. Hello.
Hello, Sharma. Thanks for the invitation.
Well, thanks for joining us, because your title of your talk and work is very intriguing. Targeted Therapies, Hype or Hope, and I really want to know what that means.
Sure. So, there is a lot of expectations about molecular targeted agents and what exactly they're going to bring to the table. But that depends on whose perspective. Is it the patient perspective? Is it the payer's perspective? Or is it the medical perspective? And obviously, when you think about molecular targeted agents, the hype is on personalized medicine, deciphering the molecular circuits of the tumors, and attributing the right drug to the right tumor in the right patient. And this obviously comes with a cost. And I think it's time now that we have 13 molecular targeted agents registered for solid tumors to try to draw a line and look back and say, well, what this exactly has bring in terms of cancer management. And to do so, I think we need to put this into perspective. The first perspective I will put in front of you is the complexity of regulation and costs for developing new drugs. You have to realize that now a pharma company has to put 1.2 billion in the table to get a molecular candidate become a drug. The cost has increased. It has doubled over the last 10 years. And the efficiency yield with which the pharma companies are being able to transform a molecular target into a marketed agent has decreased by half. Cost double, efficiency decreases by half. So this process is not very efficient, it's very costly, but that's the reality. The second thing you need to realize is that drug development in oncology is much more complex than it is in other fields of medicine. When you develop an antihypertensive agent, you just need to demonstrate that your drug decreases blood pressure. In oncology, you need to demonstrate that you are superior to the best standard of care. And that's normal because there is a life at stake. It's not just blood pressure going up or down, it's your life. So it makes sense. Nevertheless, because you are comparing yourself with the best standard of care, and because the standard of care has improved over the last 10 years, the threshold to approve a drug is becoming higher, higher, higher. So this is very important. And finally, you need to realize that when a drug comes in oncology, it usually is tested in very advanced setting, metastatic, third, fourth line. And before the whole benefit of the drugs happens, you're going to have to move from third, fourth line metastatic to second line, first line metastatic, locally advanced, and adjuvant. And in fact, it's in adjuvant where the added value is the greatest one, but because that's where you have cure. Look at Herceptin. It took 15 years for Herceptin to move from metastatic to adjuvant. 15 years. But Herceptin is saving lives in adjuvant, many, many lives. It's calculated it's around 12,000 lives in Europe per year. It's huge. And obviously metastatic setting, it allows many women to have additional number of years of life, which is great. So this is the first perspective. The second, obviously, that a lot of people are going to argue about is the cost increase. And I don't know the numbers for Europe, but I know the numbers for France. And the reimbursement, total reimbursement value for molecular targeted agents has moved from 500 million euros in France in 2005 to 1 billion euros as of last year. Nevertheless, although €1 billion seems a lot, you need to think about, well, how much money is there for healthcare in France? And, €1 billion is just 0.7% of all the healthcare expenditures that are reimbursed in France. So, it's money, but it's only 0.7%. So, is that money worth? That's the true question. And I will say that it really depends on the targeted agent, and here is where things are a little different. I think there is no doubt Herceptin, there is no doubt rituximab, there is no doubt Gleevec have brought great things into oncology. And these agents have good biomarkers. So targeted agents with a target in the tumor makes a lot of sense. There are some other so-called molecular targeted agents where the target is not so clear. The anti-angiogenic agents. What's angiogenesis? It's a very transversal and diffuse process. It's not a specific target. It's not a receptor you can measure. Mm-hmm. So that's why it has been so frustrating to try to find a biomarker for anti-angiogenesis. Nevertheless, some anti-angiogenic agents, Avastin, Sutent, Sorafenib, have changed the outcome of kidney cancer. I mean, before you only got interferon and a few months of life. Now you have a few years of life in the metastatic setting. That's a big difference. And I will argue that, we really need to reinforce the work on biomarker-driven selection of patients, and mTOR inhibitors and anti-angiogenic agents are not doing well in that regard. We need to improve that. And I will finally argue that, we need to work on two other topics. One is the cost. I don't think it's right to define a definitive cost for a drug, whether you are using it in metastatic or adjuvant. I think the cost should be linked to the benefit you are bringing to the table. If you are curing someone, you should get much more money. If you are just prolonging part of the life of the person, even if this is not nice when you think about the patient perspective, from the payer perspective, it makes a lot of sense. And the other point that we need to work on is the tolerability of these compounds, And yes, they bring additional life, but this needs to be done without hurting too much the quality of life. And many of these agents are given in a chronic manner. And while we were used to accept a threshold of side effects with chemotherapy that was, you had 2 or 3 days of chemo every 3 weeks. So it was okay to be crappy 2 or 3 days, because then you had 3 weeks to recover. Mm-hmm. If you take a pill every day that makes you a little crappy every day, it's not okay anymore. If you have diarrhea grade 2 every day, you feel very poor. I mean, imagine you have to pull out of the highway because you cannot wait for the next oil station or gas station. That's not right. We need to improve that. We need to have different scales for evaluating toxicity in these compounds. Nevertheless, I think, yes, they are bringing great hope. Patients are right to look after personalized medicine as the way forward, to find where's their target in their tumor, and is there a drug that matches that?
As you were speaking earlier about Herceptin, and I was thinking about when it was denied approval in the UK. And to me, that's an example of what it must be like for a patient who knows that this is a drug that has had known efficacy, but due to cost, it was not available, and it resulted in litigation. So my sense is that in the United States, the many drugs are approved by the FDA, and it's up to physician uptake and utilization to get them actively involved in the system. But in Europe, it's a cost issue, and the governing bodies like NICE that may or may not allow a drug, even if it is known to be effective, access because of cost. Now, who knows what's going to happen in the States? But is that a fair analysis?
I think NICE is an example of where I don't want my country to go, and I hope France won't go to NICE. France is a system which is quite nice because we have every citizen that is covered by Social Security, and we don't have a NICE system. So the uptake of molecular targeted agents in France is huge, and when you look at the survival rates in the Euroscan survey, the worst survival rates in the Western European countries is UK, because you are denying a lot of great drugs for the patients, although they have very good doctors. But if they don't have the right tools, they don't get a good outcome. While France has one of the best survival rates. And no surprise, a lot of the English or British citizens that have a secondary house in France now, they just come for therapy in France if they get cancer, So I agree, but here we are mixing two things, and I think this is important for the doctors to understand. I am MD, and I want to do the best for my patient, okay? And I don't think it's completely right to ask an MD, when he knows about the efficacy of a drug, to integrate and make the decision about should I use this or not based also in the cost. Because that is not a doctor perspective, that is a citizen perspective. Is my country rich enough to allow this cost for this survivor? That's completely different. I didn't make my oath as a doctor to use economics on it. That's the citizen perspective. I can vote for these MPs or not these MPs, and it's for the MPs to stand up and say in France, well, we're going to do nice, and a life will cost 50,000 euros. I'm not sure any MPs in France is going to stand up and say this is the threshold. I'm amazed that the British accept that system. It's unbelievable. Sometimes they were randomizing whether you were living on the left or the right side of the street. But, you know...
The postal code lottery.
Absolutely, the postal code lottery. So I agree. Costs are increasing, things are evolving, but at the same time, you know, you need to take into account that a patient that is being treated and stays alive generates, for the country, good. He's taking care of the grandkids, he's going and buying coffee, he has a car that works. I mean, all those positive parts of a patient being alive are not taken into account in many of these systems.
Well, I appreciate what you've done, which is sort of break out and analyze the different factors that go into the approval process and what's realistic. So I am hopeful as a survivor for the future of personalized medicine and targeted therapies. I think that one of the key points that you spoke about is that we as consumers, the public, as patients, must understand what goes into bringing a drug to market. The companies absorb all the risk, and most of the compounds don't result in the desired goal, and so it is very, very, very expensive, especially in the era of biotechnology, to manufacture drugs that will make a difference and really show long-term effect and efficacy.
No, I fully agree with that statement. And you know, it's very simple once that drug is there market and is reimbursed for 3,000 euros a month to say, oh, this is outrageous, look how much money they make about it. But they have to tell that for one compound market there is another 9 who died there. It's the same analogy I use when some students tell me, why do you say that tobacco is not good? Because my grandfather is alive and he smokes like crazy. I say, for your grandfather alive, there is 9 of them dead. So, but they are not there to tell you they are dead. You only see the one who is surviving. Same for drug registers. You see the one that is registered that may make benefits for sure. I mean, pharma companies are not here for philanthropy, that everyone knows that. But all in all, with one compound register, usually there is 10 deaths and 10 compounds that never make it to the market, and that's a lot of investment. So the system needs to keep some balance between, you know, input for research and investments in oncology going on and return on investment for the pharma company. And then we need to find the overlap between what is the interest of the pharma, the interest of the patient, and the interest of the doctor. And we are well when the three interests are together.
And what's in the best interest of the patient?
Absolutely, absolutely. The patient is, at the end of the day, the person that is suffering. And, you know, when your life is at stake, a lot of things change in perspective, you know. And I really think the era of oncology is completely changing today. There is great hope and great expectations. And obviously, when you're a patient, you always want all of this to move ahead forward quickly, because time for you can be your life.
Thank you, Dr. Jean-Charles Soria from the Institute Gustave Roussy in France. I hope I said that right.
Absolutely.
And thank you for this very, very compelling, thought-provoking paper presentation. There's going to be a publication, you said, coming up soon?
Yes, this is going to be presented this afternoon at the ESMO meeting in the patient seminar, and there is a manuscript that is going to be coming out in Annals of Oncology.
Thank you very much. I would look forward to the next phase of your analysis of drug development.
Thank you.
Pleasure talking to you.
Same. Bye-bye.